Hi everyone, I have this week's clinical presentation and I decided to do it on Hashimoto's for the endocrine section. So just to review the pathophysiology, it is an autoimmune disease that attacks the thyroid, most commonly causing hypothyroid disease. So we will touch a little bit on hyperthyroid, but the majority of this presentation will be over hypothyroid disease. So when you hear Hashimoto's thyroiditis, that's just referring to, the autoimmune process behind why that patient is presenting with hypothyroid disease. So it involves the formation of antithyroid antibodies that attack the thyroid tissue, causing progressive fibrosis. So we do know that this is the most common cause of hypothyroidism in America, due to the sufficient amount of iodine intake. Not really a problem there in the US. And it affects about 5 in every 100 people. It is also almost 10 times more likely to develop in women rather than men. And it usually presents in like the 30 to 50-year-old group. It is more likely to form if that patient has another autoimmune disease, such as celiac disease, rheumatoid arthritis, lupus, or type 1 diabetes. In rare cases, very rare cases, it can lead to hyperthyroidism. Just like the other autoimmune diseases, it is genetically linked, so it's more common in families with a history. And then viruses like hepatitis C can also cause it, but it's more due to that autoimmune disease. So I'm sure all of us know how to locate a thyroid by now, but I just wanted to include a diagram. Usually they are, can be kind of hard to palpate. I see a lot of providers chart, due to like body habitus or, maybe there's a bunch of nodules surrounding it. But it is important to know what normal feels like and how to properly assess it. So I've only seen one provider in my whole clinical rotation actually stand behind the patient and palpate the thyroid that way, and that is, the correct way we are supposed to do so. So signs and symptoms aren't really that hard because it's just the signs and symptoms of hypothyroid disease, which has been absolutely drilled into our brain since nursing school. So hypo, think low and slow. That's the weight gain, hair loss, constipation, skin changes, infertility or cycle changes. You can have that cold intolerance, slow heart rate, heavy periods, and then also some joint and muscle pain. So I'm sure every single one of us has seen this picture, whether in NP school or nursing school. And I just wanted to also go over a little bit of hyperthyroidism and what that looks like. So we talked about the signs and symptoms of hypothyroidism in patients with Hashimoto's. But just remember that hyperthyroidism, you're looking for that tachycardia, bulging eyes, finger clubbing, tremors, also menstrual changes, but this is more of that amenorrhea, so not having a period. Edema, breast enlargement, enlarged thyroid. So it is important to note that you can get a goiter in both hypo and hyperthyroidism. So we just know that a goiter is an enlarged thyroid, and that would lead us, if a patient just comes in and we palpate this large or generous thyroid, we would want to do an ultrasound because is it large because there are nodules on it, or is it just truly a goiter? And then also labs associated with that. So the diagnostic tools here really aren't that hard. We do want to do a good physical assessment, and that's looking at hair, skin, nails, thyroid palpation, heart and lung sounds, because with hyperthyroidism, that's when you can get some of that irregular heartbeat. Review of systems and HPI with the patient. Of course, I talk a lot about fertility and menstrual problems because I'm in women's health, so I feel like that's a big one that we assess. But asking them what they're noticing at home, when they're not in the office, and if they're complaining of any of those skin changes or heat or cold intolerances. And then finally, labs and imaging. That thyroid ultrasound will be helpful. And then we'll also be drawing the TSH, T3, T4, but the most important one to diagnose Hashimoto's thyroiditis is that TPO. So that's thyroid peroxidase antibody, which is what will be found in a patient with Hashimoto's. So treatment, as we all know, because hypothyroidism is so common, that includes that levothyroxine or Synthroid. And then hyperthyroidism is the methimazole or propranolol. And then lifestyle modifications, which I think is huge for any patient that comes in with an autoimmune disease, is talking about that anti-inflammatory or autoimmune diet. I know if you have TikTok, that's really going around, and I feel like a lot of people with autoimmune diseases are speaking out about that and how helpful it is. I know we're not nutritionists, and it's really awesome to refer these patients to maybe even a holistic or, nutritionist. It's important to know that some of the foods to avoid if you're trying to adapt this type of diet are inflammatory proteins, which are avocados, seaweed, radish, nuts, mustard seeds, cashews. A lot of those have a lot of salt in it too, which would kind of do the opposite. So another thing they need to avoid is gluten, sugar, especially like refined sugars, high fructose corn syrup, stuff like that, and then fatty acids. So education for these patients is super important. What happens if we don't treat? So what happens if we don't treat their hypothyroidism and they just keep on going the way they are? So we do know that untreated hypothyroidism can lead to high cholesterol, heart disease, heart failure, high blood pressure, and then that myxedema coma. And then of course it can cause problems during pregnancy. So recently, the docs that I work with are drawing a TSH monthly throughout the pregnancy, because we do know that poorly managed hypothyroidism during pregnancy can cause preeclampsia, anemia, miscarriage, low birth weight, stillbirth, and very rarely in the mother, congestive heart failure. So as I kind of mentioned in that last slide, we know that eating foods that have large amounts of iodine, such as kelp, other kinds of seaweed, and certain iodine-rich medicines can actually cause hypothyroidism or make it worse. So kind of stay away from the iodine supplements, check their supplements and make sure it doesn't contain that. And then to really take their medications on time and as directed. As we know, Synthroid needs to, be taken in the morning on an empty stomach at least 30 minutes before they eat any food. And then contact their healthcare provider if signs and symptoms are getting worse. We only check on them really every couple months. And they might be able to tell us if their thyroid is off before we can. And then getting them in to see that nutritionist so they can go over an anti-inflammatory diet would be very beneficial too.